Well done, Lisa, you're doing really well. That's it. Fantastic. That's it. Brilliant. Okay, Nicole, you can just see that the baby's head is just starting to come down. You can just see it there. Well done, Lisa. That's it. Just go with it. It's not going to be long now. We're going to have your baby, all right? Well done. You're doing so well. Well done. That's it. Fantastic. Brilliant. Okay, you just move to wherever you want to be, that's absolutely fine. I think it's not going to be long now until you have your baby, alright? So you just go with these contractions, alright? Well done, that's it, keep going. Lovely, okay, baby's head's coming now. Fantastic. Well done. Okay, now we just breathe for me, Lisa. Just breathe, that's it, from your way. That's it. Lovely. Okay, let's baby's head delivered. Okay.
The midwife observes delay and that the presenting part is no longer advancing. Turtlenecking is noted.
Okay, Nicole, I think we've got a shoulder dystocia here, okay? Yeah. What I need you to do is go and call an ambulance for me, alright? We need a paramedic ambulance. We need to tell them that we're having a shoulder dystocia at home birth. Okay? Okay, your baby's shoulders might be stuck, okay? So what I'd like you to do is not push with the next contraction, alright? You're going to get an overwhelming urge, but just see if you can not push, okay? Baby's going to be fine, but there might be some things I need to do to help baby out, okay? The first thing I'm going to do is lie you flat on your back. I'm going to take these bean bags away, okay? With your next contraction, you're going to feel like you need to push. Don't push, okay? Just try and breathe through it as much as you possibly can, okay? Okay, and lay yourself down, that's it. Lisa, with your next contraction, I don't want you to push.
The midwife assists the woman into the McRoberts position. This is the first choice of action. The woman needs to be lying flat on her back. She is helped by the midwife and the student midwife into an exaggerated knee-chest position. One pillow is acceptable. In most cases, this will resolve the problem. Note that shoulder dystocia is a bony problem. The midwife here is using the model to demonstrate how the anterior shoulder is wedged up against the symphysis pubis. Traction at this point would compound the problem, as the shoulder would become further impacted against the symphysis pubis. 30 seconds of continuous suprapubic pressure is now applied, with the aim of dislodging the anterior shoulder off the symphysis pubis. If this is unsuccessful, it is followed by gentle rocking of the symphysis pubis. The midwife should apply pressure using the flat part of the hand against the baby's back in the direction that the baby is facing. In practice, meanwhile, gentle traction would be applied by another midwife. The midwife is now demonstrating gentle rocking of the symphysis pubis. If these methods do not expedite delivery, the midwife will need to perform internal manoeuvres. First, a short rotation can be attempted using Rubin's manoeuvre as demonstrated by the midwife here. She places 2 fingers posteriorly into the vagina to locate the posterior shoulder. With the other hand, 2 fingers enter the vagina anteriorly and pressure is applied to the posterior aspect of the anterior shoulder to rotate the fetal shoulders into the oblique diameter and off the symphysis pubis. Gentle downward traction is maintained at the same time. Rubin's manoeuvre is again demonstrated outside of the mannequin. If rotation in one direction is unsuccessful, rotation in the opposite direction should be attempted. The midwife places 2 fingers into the vagina anteriorly to locate the anterior aspect of the anterior shoulder. With the other hand, entering the posterior vagina to locate the posterior aspect of the posterior shoulder in order to attempt an anti-clockwise rotation. This manoeuvre is again demonstrated outside of the mannequin. If all previous manoeuvres have been unsuccessful, delivery of the posterior arm should be attempted. The midwife enters posteriorly along the curve of the sacrum to locate the posterior arm. The fetal arm is moved over the fetal chest and delivered. This reduction in the presenting diameter should facilitate delivery of the baby using gentle downward traction. There is no correct order in which to perform these manoeuvres. For example, the posterior arm may be delivered first if this seems to be more appropriate. Also think about the position of the woman. Consider a complete change of position, for example, moving her onto all fours.